Okay, coming to tricuspid regurgitation, as you can see, there would be leakage of blood that would be occurring from the right ventricle into the right atria of the patient. So this would be resulting in a development of a pansystolic murmur in the patient on the likes of mitral regurgitation only. However, the causes for tricuspid regurgitation are starkly different from that of mitral regurgitation. If the question says what is the leading cause of tricuspid regurgitation, then the answer should be given as functional. While I'm writing that before you, I want to remind you that in the previous topic, tricuspid stenosis, I said it is coexistent with mitral stenosis. So most of the time the causes are identical. It could be most of the time a rheumatic process. But in tricuspid regurgitation, it's mainly functional. What I mean by functional is due to tricuspid annulus dilatation. Like let us say a patient is having dilated cardiomyopathy. Now here there's a dilatation of the heart, there's an enlarged globular heart, so the tricuspid annulus and the mitral annulus also dilate, and because of that the valve leaflets are relatively not able to approximate properly and the blood can leak. So functional due to, as I said, tricuspid annulus. Why am I emphasizing on this is because traditionally it is the valve leaflets which are damaged, and that is why we study about a regurgitation lesion. Here I'm saying that there's no problem with the leaflets, but the compliance of the leaflets may even be normal, but they're not able to approximate properly as they normally are able to do, primarily because the annulus is dilated. Now this happens to be the number one reason, but tricuspid regurgitation could be secondary to also severe pulmonary artery hypertension. I have explained that routine pulmonary artery hypertension is defined as pressure more than 25 mm of mercury at rest or more than 30 mm on exertion. Do remember, normal mean pulmonary artery pressure is 15 mm of mercury. Anything more than 25 at rest or more than 30, double of 15 is 30. So 30 on exertion is pulmonary artery hypertension. Severe would be defined as pressure more than 55 mm of mercury. So here the pressure is so high that this pressure is transmitted to the chamber of the right ventricle, and the pressure of the right ventricle can definitely become so high that it could result in a defective coaptation of tricuspid valve leaflets and the blood could leak to the RA. So do not be surprised if in pulmonary artery hypertension he mentions a pansystolic murmur in the long run. The second reason why this can happen is due to right ventricular pacing. Now when you put in a pacemaker, the pacemaker will be having leads, like one lead would be touching right atria, another lead would be touching the right ventricle, the third would be touching the left ventricle. So traditionally nowadays we use triple lead pacemakers. In triple lead pacemaker there are three wires, one controlling RA, RV and LV. So each of these wires will be controlled by the computer, the microprocessor, and it will ensure that all chambers of the heart contract when the computer decides. Obviously first atria will contract, then ventricles will contract, and when the ventricles will contract, both should fire simultaneously, because if there's a time lag between the firing of ventricles, there could be a pulmonary edema. So basic function of the pacemaker is that it should ensure a synchronous contraction of both of the ventricles. But when you're putting these wires in the heart, these wires can perforate the leaflet, or because of the presence of these wires per se, there could be local damage to the valve leaflet. They may not be able to close properly. So right ventricular pacing has been one of the important causes for development of tricuspid regurgitation in the long run. Then important cause from MCQ perspective is carcinoid heart disease or carcinoid syndrome. You see, having a carcinoid tumor does not always mean person will develop carcinoid syndrome, because lots of time carcinoid tumor, whatever it will produce, let me say carcinoid tumor is in the gut, it is in the appendix, or it is in the cecum, then whatever it will produce, it will be traveling by the portal vein into the liver, and the liver will deactivate all of those 5-HT derivatives. But if the carcinoid tumor is in the lung, then whatever 5-HT derivatives it will produce, they will flow into the heart. They can damage the left side of the heart, they can damage the right side of the heart. So in carcinoid syndrome, I want you to remember a mnemonic of valvular lesion, which is by the name of TIPS. TIPS would stand for the topic that we're studying, tricuspid insufficiency / tricuspid regurgitation. Here, for convenience of the mnemonic, I want you to remember TIPS. Tricuspid insufficiency and pulmonic stenosis are two valvular lesions that are seen with carcinoid heart disease, with tricuspid regurgitation being relatively more common. Another reason why this could be having is why the person could be having tricuspid regurgitation is rheumatic heart disease. That's a unanimous, a problem in India. Then could be radiation to the heart. Like this person had undergone Maybe if it's a female patient, she underwent modified radical mastectomy and then she had a recurrence of breast tumor, so radiation was given. Or a person was having lymphoma related to Hodgkin's lymphoma related to the hilar lymph nodes. Now, if it is a localized disease, then we can give radiation for Hodgkin's lymphoma. So radiation will cure Hodgkin's lymphoma but will damage the heart. The next cause for damage to the tricuspid valve leaflets is endomyocardial fibroelastosis. As the name suggests, fibroelastosis, there's a development of fibrosis that damages the conduction system in the heart as well as the endocardium. So valvular lesion in the form of TR can be seen in a patient. Then would be standard infective endocarditis. When it comes to rheumatic heart disease and infective endocarditis, these are obviously two standard things that would be present in any valvular heart disease. But then the other aspects that I've explained to you, like the damage caused by the pacemaker leads or the radiation or the endomyocardial fibroelastosis and carcinoid syndrome, yes, is an important fact. From pediatrics perspective, tricuspid regurgitation is associated with Epstein anomaly. Another MCQ I want you to remember, I can call it an MCQ, and MCQ is that Epstein anomaly is associated with bundle of Kent, that is Wolff-Parkinson-White syndrome. And why that is important is because Epstein anomaly is related to two things now. One, it is related to TR, so pansystolic murmur, and second, WPW association, so delta wave in the ECG could be present. So I definitely want you to remember that if mother is a patient of maniac depressive psychosis and she has an accidental pregnancy and she was in lithium when she conceived, then the baby will develop Epstein anomaly. And two things associated are TR and Wolff-Parkinson-White syndrome. Both could be associated with patient, and therefore in a multiple choice question he can mention about a child having a pansystolic murmur and a pre-excitation syndrome. Now let us look at the symptoms that would be encountered in these patients of tricuspid regurgitation. The primary complaints of these patients would be due to low cardiac output, because the blood of the right ventricle is leaking back into the right atria, so there would obviously be less blood going to lungs. That means that the ability of these patients to perform like us, like climbing stairs or carrying a backpack on a back, would be relatively lesser. So effort intolerance is one of the early symptoms that would be noticed in the patient. And then in fact I can just draw a line diagram for it so that this makes more sense. I have shown here tricuspid valve leaflets bulging up and not being able to approximate properly. So the end result is leakage of blood from RV to RA in the patient. You can see that this is systole happening at the moment. Left side, no problems, but on the right hand side you can see the blood leaking. So because less blood is going into the lungs, I mentioned regarding effort intolerance. The second feature which would be very prominent in these patients would be, as you can see even in this diagram, and I'll just zoom it in, this was a patient from South India who had actually presented with these very prominent pulsations in the neck, and you can see the huge jugular vein column that is coming up here. That is a CV wave which is present in these patients, and that CV wave is because there would be no X descent. You see, after C there will straight away be a V wave, so therefore in these patients cervical pulsations will also be a complaint. So two reasons why these patients primarily come to you. The TR patients would be effort intolerance, cervical pulsations, and ultimately because the liver of even these patients would be involved in the long run. So findings of abdominal fullness. Obviously, I mean, the patient will not say hepatomegaly, person will just say abdominal fullness. And when you do a per abdominal examination, the liver span of these patients would definitely be increased. Apart from this, asthenia, tiredness, fatigue are other features that are explained by these patients. And when you will examine the patient, you will notice that the JVP finding of this patient will be very characteristic. There will be absent X descent. Why? Because X is coming down and this is going up. So in these patients, the vector will cancel and therefore you will be having a CV wave. And if the CV wave is there, therefore in these patients, there will also be a presentation of a steep Y descent. Remember what I said in tricuspid stenosis was a blunted Y descent. Here I'm saying a steep Y descent in a patient, and you can see here also as the severity of the disease will increase. I'll just mark out the normal before you. This is A, then we have a C, and then we have a X. In a normal person, you will have a X descent, but in these patients, because the vector of TR is pointing upward, so the X will progressively start getting reduced. So you can see that as the disease will become more severe, the X is literally disappearing. and then you are having only a followed by a big CV wave. This is what I am talking about, the CV wave, and then everything that comes down very fast, that would be called as a steep Y descent in a patient. So prominent neck pulsations, I'll just zoom it in so that you can just relate to this better. I said the vector of X should come down. It won't be able to come down. Why? Because there's a TR that is happening upwards, so the X would become relatively smaller, and then in these patients not only the X will disappear, but after C directly the V would come, so a CV wave, and then would be a steep Y descent that would be developing in a patient. So that's one of the standard things that they usually ask you in questions related to tricuspid regurgitation. Plus there will be a hepatomegaly. The enhanced liver span of the patient will be there, and he will also mention the word pulsatile liver. This time the pulsations of the liver will be during the phase of systole. When the ventricles are contracting, this event is occurring. So pulsatile liver would be offending, and then these patients would be having a pansystolic murmur, PSM. This pansystolic murmur will increase on inspiration. As I've highlighted before you, that all right-sided events, they tend to increase with inspiration, primarily because more blood is coming, so more turbulence would be present. So this pansystolic murmur of tricuspid regurgitation increasing on inspiration will differentiate it from the murmur of mitral regurgitation, and this is what you read about Caravello sign. So though Caravello sign is, I would like to say, more asked in university exams, but still because it is mentioned in the book, I have mentioned here. From the exam perspective, I want you to remember mainly the CV wave which is present in this patient, and the term, the technical name for the CV wave in the patient is referred as Lancisi sign. So from the entrance exam perspective, I want you to remember Lancisi sign, which is specific for tricuspid regurgitation, the CV wave. And yeah, I mean, in university they can definitely talk about Caravello sign, which is how you differentiate MR from a TR. On deep inspiration, the TR murmur will become louder, and therefore, I mean, you would be able to appreciate that this is a right-sided murmur, because right-sided events tend to enhance or get enhanced during the phase of inspiration in a patient, and the same murmur will tend to decrease on Valsalva, standing, and amyl nitrate. As I've said, all murmurs decrease on Valsalva, standing, amyl nitrate. Why? Because standing will cause less blood to come in the heart, so decreased venous return, less blood means less turbulence present in the heart. Coming to the workup of patients of tricuspid regurgitation, one of the investigations that I'll do in this patient will be a ECG. On ECG, most of the time the findings that can be obtained for these patients would be that of a right axis deviation, since the right side of the heart is the one which is relatively enlarged, or if there is, let me say, presence of pulmonary artery hypertension, so P pulmonale in the ECG could be found. So primarily findings related to right-sided pathology can be appreciated on the ECG, and on a chest X-ray, one, you will definitely have a cardiomegaly. The CT ratio of the patient could be increased. Now, why is the CT ratio increased? It could either be due to right ventricular failure, or it could be dilated cardiomyopathy which has resulted in a functional TR. So by X-ray we can't pinpoint the exact cause, but speculation is one reason why the heart is enlarged is there's a failure of the heart. Second reason is that the etiology behind this could be cardiomyopathy, so the CT ratio is more. The pulmonary artery segment of this patient also looks relatively prominent, because this area should normally be concave, but it is convex. And then you can also notice the prominent contour of the right atria of the patient, which signifies a right atrial enlargement of the patient. So all the findings of ECG and chest X-ray will definitely tell you that the disease process is mainly right-sided. For nailing the diagnosis, you will be doing a echocardiography, which will definitely show a jet of blood which will be racing from the right ventricle to right atria at a significant pressure gradient, and higher is the pressure gradient, more severe will be the features. And when you switch on the Doppler in this condition, you will be able to definitely identify the blood leaking from right ventricle to the right atria. Simultaneously in these patients, you would also be able to notice a very interesting finding, which is the reversed systolic flow in the hepatic vein. Traditionally, the blood of the liver should flow towards the heart, but here I've written a reversed systolic flow in the hepatic vein, which is a good pointer if given in the MCQ towards presence of tricuspid regurgitation in a patient. Depending on the age of the patient, even coronary angiography is warranted, because a lot of these patients are relatively old age, because like a dilated cardiomyopathy could be occurring due to post ischemic cardiomyopathy, like he had a coronary artery disease, and then due to ischemic cardiomyopathy he has had tricuspid regurgitation part. So angiography depends on the decision of the physician, especially in old age patients where there could be concomitant angina present. You might have to do an angiography in the patient. For management of the disease per se, one of the important things to be used is diuretics and aldosterone antagonists, because these patients would be having is a development of ascites and a liver congestion. And then the surgery which is done for these patients is a tricuspid valve repair. The prognosis of this condition is good if in case the diagnosis is made on time, and either a repair or a replacement is warranted for this patient. And again, I would like to say the same thing. If the valve replacement is planned for this person, then we can either choose between a metallic device or a prosthetic device. And if we choose a metallic device, then a lifelong anticoagulation might be required for these patients as well. So you need to remember a comparison between TS and TR, in a sense that TS will be having a JVP finding of a large A wave and a blunted Y, and tricuspid regurgitation will be having a very classical Lancisi sign, that is a big CV wave occurring in a patient. And along with that, there would be a pulsatile liver which would be seen in these patients. In TS, it would be presystolic pulsations of the liver. So as such, TS and TR are relatively straightforward topics and can easily be worked out. We shall now talk about a pulmonic stenosis. Pulmonic stenosis, on the other hand, is a disorder that is mostly found in pediatric age group. It is rare to have pulmonic stenosis as an adult presentation. If it's a congenital presentation, mostly will result in cyanotic heart disease in a patient. Sometimes in MCQs, you might read the word dysplastic heart valves or dysplastic pulmonic valve. This is a feature that is seen with Noonan syndrome. Noonan can look like a person of Turner syndrome. You all know that in Turner syndrome, you have characteristic webbing of the neck, and Turner will obviously be a female 45XO, but you can see here I've shown a male, and this male is having a webbing of the neck. So Noonan syndrome looks like Turner syndrome, but there are definitive differences. Like Noonan is related to chromosome number 12, whereas Turner is obviously a aneuploidy by the name of 45XO. Do remember the fact that the most common congenital heart lesion that is found in patients of Turner syndrome is bicuspid aortic valve. The second most valvular lesion that is found in Turner syndrome is coarctation of aorta. But if he says what valvular lesion or heart disease congenital can be present in Noonan syndrome, then answer should be given as pulmonic stenosis or dysplastic heart valves. The third reason for pulmonic stenosis is carcinoid heart disease, carcinoid syndrome. The 5-HT derivatives can contribute to two valvular lesions by the name of tricuspid insufficiency and pulmonic stenosis, and tricuspid insufficiency incidence-wise is relatively more common. The fourth cause why pulmonic stenosis can develop is due to rheumatic heart disease. Now, I would like to clarify here the fact that OP Guy says that it is never involved, but in Harrison it is mentioned rheumatic heart disease as rare. So we will have to imbibe both the informations there, and obviously different authors can have differences of opinion. So we as doctors need to keep an open mind for this. Now, when would you say severe pulmonic stenosis? The diagnosis of severe pulmonic stenosis is not based on the orifice size, but is based on the pressure gradient, because this heart lesion will depend on the pressure gradient between the right ventricle and the pulmonary artery, because pulmonic stenosis will contribute to right ventricular hypertrophy in a patient. So severe pulmonic stenosis is defined as a pressure gradient of more than 50 millimeter of mercury, and because of this higher pressure gradient, the forward flow will definitely be compromised in the patient. So one, exercise intolerance and I would say early fatigue can be a feature of these patients, because the pulmonary flow is compromised in these patients. In fact, most of the time, if the patient is having mild pulmonic stenosis or moderate pulmonic stenosis, then the symptoms may never be present also. Early pulmonic stenosis in adults usually does not cause symptoms. Now that is very striking, because in pediatric age group you will be having a pulmonary oligemia and cyanotic heart disease coming up, because it could be related to multiple other malformations and the right-sided heart flow can be reduced. But in adults, if PS is present, like let me say due to carcinoid syndrome, most of the time it is asymptomatic. Only when the pressure gradient is very high that you will start having manifestations. So let us now see what will be the manifestations that would be occurring in patients of PS. One of the characteristic features that would be noticed in these patients would be a development of a ejection systolic murmur. This is what I'm saying. The orifice is relatively narrow. There will also be a development of right ventricular hypertrophy. So when the ventricles will contract on the left hand side, there will be a smooth ejection of blood, but here there will definitely be a turbulence, and this turbulence is maximum during the middle of the systole. So that is why I said the patient will be having is a presentation of a ejection systolic murmur that would be best heard in the second intercostal space on the left side. So this is what I'm saying. When you will auscultate this patient during the phase of systole after S1, you obviously have is a ejection click where the aortic and pulmonic valves open, and then the murmur will peak, and then the intensity would go down. So you will read about what is called as a ejection systolic murmur or a crescendo decrescendo murmur occurring in the patient. Now what I'm gonna do is that in the same diagram, I'm gonna make this lesion relatively smaller. Like if the orifice is relatively smaller, then the pressure here will rise, and higher pressure will result in early opening of the valve. You can see here that I have changed the position of the ejection click in this particular patient, in a sense that if the opening is relatively narrowed, then the higher pressure will cause a early opening of the valve, and therefore you can notice in the patient that the distance between the S1 and ejection click will reduce. I'll just zoom it in here so that you can relate to it. What I'm doing here is similar to what I've done even for mitral stenosis. In mitral stenosis, I have been talking about gap between S2 and opening snap, but here I am talking about gap between S1 and ejection click. So I would like to say like this, that the severity of this particular disease, severity of pulmonic stenosis, is inversely related to S1 and ejection clip gap. And why I'm saying this is because as the disease will become relatively more severe, the ejection click will come closer and closer. If I make it more severe, the ejection click will come closer. Why? Because the pressure is higher. So as the ejection click will come closer to S1, it will merge with S1, and you will not be able to differentiate between S1 and ejection click separately. So for severe pulmonic stenosis in a patient, ejection click usually will not be heard. I'll just write down the theory here that is to be remembered by you. These patients have a ejection systolic murmur. The ejection click tends to become merged with S1, so ejection click may not be heard in these patients. Why this is important for you to remember is that traditionally, whenever we talk about right side of the heart and whenever we talk about events of the right side of the heart, they always tend to become more prominent. There is only one event on the right side of the heart that will become less prominent with inspiration, and that is ejection click. Remember my statement once again. I've been saying this again and again, that everything on the right side of the heart will become more prominent with inspiration, but the ejection click tends to become relatively lesser. Why that happens can be explained by the explanation that I have mentioned here before you, that the ejection click with more blood present in the right side of the heart tends to come relatively closer to S1, so it may not be heard. You see, after all, if there are two sounds like S1 ejection click, there has to be a gap between the two for you to appreciate which one is which one. If the gap between the two will reduce, you will not be able to identify them. So my statement, which is the MCQ one, is that all right-sided events tend to increase with inspiration. I stands for inspiration. The exception to this rule is a pulmonary ejection click. This question has been asked in JIPMER and couple of other exams, so you need to remember this statement. The explanation is here in front of you. The gap becomes relatively lesser in the patient. Another finding which is to be remembered for the MCQ sake is that in these patients, when you will hear S2, that is A2 and P2, A2 will be heard normally, P2 will be delayed, and the P2 might be so soft. Why I'm saying so soft is because the pulmonic valve leaflets will hardly be able to move. Why? Because there is a pressure gradient which is operating like this. You see the pulmonary artery pressure in this particular case versus right ventricular pressure. The right ventricle has to operate against a gradient. There is obstruction present. So the P2 exertion or the range of movement of the pulmonic valve is lesser. So P2 in this patient can be so soft that it may not be heard. So remember my words here, and I'll just write it down separately. Loud P2 is a feature of pulmonary artery hypertension. Why? Because the high pressure of the pulmonary artery will slam the valve from behind. So when it presses on the pulmonic valve from behind, the P2 becomes louder. But in pulmonic stenosis, because the range of movement or the exertion of the valve leaflet is lesser, so there's a soft P2 occurring in a patient. So lots of time you might be able to hear only a single S2. Why I'm saying single? Because A2 is heard, but the P2 component may not be heard in this particular patient. Then in these patients, there might be a development of a compensatory right atrial hypertrophy, and right atrial hypertrophy can cause a fourth heart sound to be present in a patient. So let us just quickly revise the important auscultatory findings of patients of pulmonic stenosis. There is a ejection systolic murmur, the duration of which becomes longer as the disease becomes relatively more severe. Common sense, opening is small, so blood will take more time to go through a narrow orifice. As the ejection click will come closer, ejection click may not be heard. So all right-sided events increase with inspiration except ejection click, which might come closer to S1, may not be heard. Then S2, the P2 component will be softer. Why soft? Because the range of movement of the valve is lesser. In pulmonary artery hypertension, it is ulta, it is opposite. Higher pressure slams the valve from behind. It's like a door, right? It's closing. You force it from behind, so it will slam with more force. So PAH is like slamming the doors with more force, so you have a loud P2, and here the range of movement is lesser, so you have a soft P2 occurring in the patient. And then fourth heart sound in pulmonic stenosis, this would be written as right-sided fourth heart sound, is explained by the right atrial enlargement that will occur in these patients. Let's now look at the workup of these patients. In the workup of the patients, because there's a compensatory right ventricular hypertrophy developing in these patients, it will lift the apex of the heart. So if you do an X-ray, in the X-ray, the right ventricle will lift the apex. You see, right ventricle does not form the right heart border. The right heart border is mainly formed by the right atria and the superior vena cava and the inferior vena cava. And right ventricle forms the base of the heart. So whenever left side of the heart becomes bigger, then the apex is pushed laterally and downwards. And whenever the right side of the heart will be enlarged, then in the patient the apex is relatively upturned. So in the investigations of these patients, in the X-ray, there is a upturned right ventricular apex, or ventricular apex is upturned. If it is left-sided enlargement in any condition, then the apex is downwards and laterally. In the ECG of the patient, you will be having a finding of right atrial enlargement. Obviously, that would be peaked P waves in the patient. In fact, we are discussing valvular lesions on the right side of the heart. So P waves will always be relatively bigger in both the limb leads as well as in the chest leads. Comparison wise, you always have a P mitral, which is seen with left-sided enlargement. That is like in mitral stenosis cases, you expect to find a P mitral, but in this case, you would rather be having is P pulmonale developing in a patient. For management of this condition, I'll just write down the theory so that we can remember it here. Workup of the patient, the X-ray findings and the ECG findings of this patient, and echocardiography is the investigation of choice. The X-ray shows upturned apex of the heart due to right ventricular enlargement. The ECG of this patient represents or shows right axis deviation. Anytime right side of the heart is big, right axis deviation and presence of a P pulmonale. The echocardiography can measure the gradient between the RV and the pulmonary artery of the patient. The gradient between the right ventricle and the pulmonary artery will be more than 50 millimeters. There might be a right ventricular hypertrophy of the eccentric variety. Mark my words there. Concentric hypertrophy of the heart is seen with tetralogy filata, and eccentric hypertrophy of the heart is seen with patients who are having a pulmonic stenosis. And for treatment of these patients, the primary course of treatment would be to go ahead with a percutaneous pulmonic valvotomy, like we do a mitral valve valvotomy. Similarly, a percutaneous pulmonic valve valvotomy can be done. That will ease off the pressure gradient and improve the pulmonary blood flow. So therefore, the symptoms of forward flow deficiency in the form of exercise intolerance of the patient can significantly be reduced. Coming to the next disease, pulmonic regurgitation, why it develops. One of the important causes for this could be annular dilatation of the pulmonic valve. The reason for this annular dilatation of pulmonic valve is severe pulmonary artery hypertension. If you're listening to me carefully, you will notice the fact that I have today blamed pulmonary artery hypertension for two problems in the heart. One, I have blamed severe pulmonary artery hypertension for tricuspid regurgitation, and second, I blamed it even for pulmonary regurgitation, again because the pressure difference or the pressure gradient would be so high that it will dilate the pulmonic valve leaflet, dilate the tricuspid valve leaflet, and therefore regurgitation could be occurring. The second important cause can be in children post tetralogy of Fallot repair. You see, in tetralogy of Fallot, there are 4 defects, and one of the primary defects is subpulmonic stenosis. So, over enthusiastic repair can contribute to PR in the patient. The same explanation can also be given for patients who have undergone a balloon valvotomy for pulmonic stenosis. Like suppose the patient was having pulmonic stenosis, like carcinoid syndrome patient was having pulmonic stenosis. So I had advised a percutaneous balloon valvotomy, and the good thing about valvotomy is it will obviously dilate the stenosed valve, but if you dilate more than normal, then it can get converted into regurgitation as well. So most of the time either it is post procedure or it could be due to severe pulmonary artery hypertension in a patient. The clinical manifestations that will occur in the patient will be mainly related to right ventricular dilatation, right ventricular overloading. So RV is the one which is mainly infected in the patient, involved in the patient with eccentric hypertrophy. The clinical features will be that of exercise intolerance again. Since the forward flow is reduced and the blood is coming back from the pulmonary artery into the chamber of the right ventricle of the patient. Since the right ventricle would be involved, there could also be a hepatomegaly, which could be written as abdominal fullness in the patient. These are standard features of all right-sided heart lesions, that there would be a hepatomegaly, there would be a pedal edema, there can be a ascites developing in a patient. Let us now look at how the murmur of this condition will evolve. In this particular diagram, I am showing before you non-compliant pulmonic valve leaflets. I am showing diastole. I have first shown that the aortic valve is closing properly in diastole, but the pulmonic valve is not closing properly. So there will definitely be leakage of blood from the pulmonary artery into the chamber of the right ventricle. The diagram is representing diastole, and the problem in this patient is a P2 part is defective. There is no problem with A2. The aortic valve closure of the patient is picture perfect. Not a single drop of blood is leaking back on this side. But I've shown regurgitation occurring into the chamber of the right ventricle from the pulmonary artery because P2 part is defective. So when you will time out the murmur of this patient, the murmur will be heard in the phase of diastole. The murmur will start exactly from P2. Like there are 2 components of second heart sound, A2 and P2. So the murmur will start from P2 and then the noise will die down. Now, why the noise will die down is because little bit of blood is coming back in the heart, so the turbulence will die down very soon. Therefore, the murmur that is heard in this patient is called as early diastolic murmur. And what I say next is the most important statement for pulmonic regurgitation topic. This murmur is classically called as Graham-Steele murmur. And because of this classical name, I have basically explained this PR topic to you. Otherwise, as such, this murmur is easy to comprehend because this is an event that occurs very rarely, especially in patients of severe pulmonary artery hypertension. The murmur will become louder with inspiration since it's a right-sided murmur. The investigational choice for diagnosing pulmonic regurgitation is usually a echocardiography. But nowadays it has been superseded with cardiac MRI for this condition. Why cardiac MRI? Because most of the time I told you this condition can occur post surgical interventions like post TOF repair and post balloon valvotomy. So to pick up the exact anatomy of the valve, because it is important, we need to decide whether we'll give the person a prosthetic valve or we'll try to repair. The surgeon needs exact information regarding the status of the valve leaflets. So because most of the time it is a post procedural complication to know the exact distorted anatomy, mark my words there, to pick up the distorted anatomy due to damage to the heart valves, we go in for a cardiac MRI, and if it is not given, then obviously the traditional echocardiography would be given. And for the treatment of this condition, the standard treatment for all right-sided heart lesions is diuretics, so that would obviously be on, and along with that we will be using a transcatheter pulmonic valve replacement. Now earlier we were doing a transcatheter aortic valve replacement, and as we have got skill in that, we can also go in for a transcatheter pulmonic valve replacement. So therefore interventional cardiology, the role is increasing on a regular basis, and therefore you can see that the longevity of these heart disease patients will also be increased. So let us just quickly summarize the important aspects that we have studied regarding four valvular lesions for the right hand side, that is a TSTR and a PSPR. One, in all problems with the right side of the heart, there can be a presentation of a large A wave. So first I'll mention large A wave, which is very particular for stenotic lesions on the right hand side. In fact, any problem can contribute to a large A wave, but for TR, the main problem is a CV wave. Because pulmonary regurgitation occurs with pulmonary artery hypertension, so large A wave can be present. Even in tetralogy failed because there was a pre-existing severe pulmonic stenosis, subpulmonic stenosis, so large A wave could have been present in the patient. For tricuspid stenosis, an additional fact to be remembered would be that the person would be having a blunted Y descent. This was because the opening was small, so the ventricular filling part was hampered. But tricuspid regurgitation was having a presence of a steep Y descent. So one, we need to get the JVP aspects right in the patient. Then the tricuspid stenosis patients will be having a murmur, which would be in the following fashion: a diastolic murmur. The murmur will start from opening snap, peak in the middle of the diastole, go down. So I'm just writing the word MDM, and can be differentiated from mitral stenosis in a sense that left-sided murmurs tend to become louder on inspiration. The TR murmur will, however, be a systolic murmur. It would be called as a pan-systolic murmur. The intensity will remain uniform all through the duration of systole. In pulmonic stenosis, you will be having is a ejection systolic murmur or a crescendo decrescendo murmur that I have highlighted before you. In pulmonic regurgitation, there will be a Graham-Steele murmur occurring in the patient, which will be early diastolic murmur. This early diastolic murmur has a classical name, so therefore due importance for this murmur should definitely be given. Apart from this, you can also remember a specific feature with respect to pulmonic stenosis, that in patients who are having PS, the ejection click of the patient will come closer to S1, and gradually the ejection click in the patient might even begin to disappear. So if ejection click in pulmonic stenosis is absent, it indicates the fact that the severity of the disease has significantly increased in the patient. With respect to tricuspid regurgitation, you can remember an additional feature of systolic pulsations of the liver. He might write pulsatile liver, or he might write systolic pulsations of the liver. On the other hand, when it comes to tricuspid stenosis, you will again be having pulsations, but these pulsations will occur not in the phase of systole but prior to that, so the word would be a presystolic pulsation. It is mainly for these findings that I have decided to discuss this topic with you. So do revise these basic findings by writing them yourself so that you are more oriented towards these valvular lesions in the right side of the heart. These are the details that have to be remembered for this lecture. Please keep on working, keep hammering, keep focusing, and I'm very sure you'll come up with flying results. It's all about focus, guys. It's all about how much hard work can you put, how much can you concentrate. I know eyes hurt when you watch a video for long duration, you get tired, fatigue factor comes in, sitting on a chair for long duration of hours. But then this is all what this doctor is all about, right? Physical stamina, mental stamina. If you develop both of them together, there's nothing stopping you. So keep working, guys. Thank you so much for listening this one.